Thank you very much. Can you hear me? Right. Thank you very much to our three esteemed speakers for sharing their insights into the latest advancements in treatment, as well as in diagnosis of prostate cancer, breast cancer, and colorectal cancer as well. So I have several questions here, but before I ask my own questions, do we have any questions from the floor? Yes.
Good morning. My question go to Dr. Malvinder. So last time I had I attended this conference. You were discussed about is a different diagnosis methods like a biopsy, liquid biopsies. Very interesting. So here the lot of therapeutic options for cancer patients. So protein targeted treatments are, I think I never seen slide. Is there any progress on this kind of treatment approach in Malaysia? Or, because some articles they written in Nanyang Technical University in Singapore, they more focus on protein targeted treatment for cancer. So is it possible, or in very preliminary level only, or what status, where stand that kind of treatment approach? Just we wanted to hear from you.
Sure.
Yeah. Thank you.
Thank you for the question. So I think the last round when I came here, I discussed something about a diagnostic procedure called next generation sequencing. When you have cancer cells, right, cancer cells tends to secrete proteins. It secrete proteins or even the mutation in the cancer cells itself. So what we do is we actually take your tissue or your biopsy, your tissue biopsy or your blood biopsy. We send it to the lab. So those days we used to send it to US, Singapore, Taiwan, Korea. Now we can do it in-house in Malaysia itself. So you check for all those mutations. You see what is being secreted by the cancer cells, which will be different between every single patient. Not everyone is the same. But in many cancers, we know that lung cancer, colon cancer, breast cancer has higher chance to find something rather than prostate cancer. Prostate cancer is very low in the list because it is not very immunogenic. You need immunogenic cancers to provide a lot of mutations, a lot of proteins to be secreted. So for patients who have actually failed multiple lines of therapy, yes, I still send for NGS for prostate cancer, but it won't be my first choice of treatment. Because my first choice of treatment by FDA guidelines, you already have a lot of targeted therapy, which you just take oral therapy if you're hormone sensitive, your survival your progression-free survival before you progress can go up to 44 months. Okay, then only you'll progress. So then you got other treatments to go again after that. So every time a patient progresses, you do a new marker. You take a new sample, you see whether you have mutations or you have new proteins inside there, then you see whether you can target. But in prostate cancer, it's very low actually.
All right. I believe the gentleman in the middle has a question.
Yeah, thank you for the talks. Yeah, again, for the prostate cancer, because the standard line has always been, clinical examination, then PSA, and then after that, convincing them for biopsy. And always the problem comes when, which stage do we do either truss or transperineal biopsy, and convincing them for biopsy, worry about the complications. Then after that, the Gleason score, and then after that, deciding on treatment, and localized disease, and then a typical MRI. Then after that, possible PSMA, and all these things have been the standard. So I know a lot of newer studies have to look at biopsies, proteins, and all these things. But where does it all come on in a standard, on the ground? People who are doing on the front, this type of things. So how do we go about it? In a standard patient coming with urinary symptoms, the urologist sees, and the decision is MDT deciding, okay, PSA level at this level, when do I go in, and you do your MRI. And then again, the decision, is that significant, the pyretes, and then again deciding, okay, shall I hit it or not? Did you get enough biopsies? This is a challenge always for the people in the front. Yeah, thanks.
Yep. Thank you. Actually, it's a good question. But for me, it's very simple because most of the time when they come to me, the reports are all ready. The surgeons do the job for me and it makes my life much more easier. Okay. But not to undermine those basic tests and all, those basic tests still have a lot of significance. Okay. For example, if you're talking localized disease, okay, I still need a biopsy. Because I cannot do Gleason score on liquid biopsy, or I can do on a tissue biopsy, but I cannot do on a liquid biopsy. Now, Gleason score is very important for a localized disease because it will determine what is your ADT period you will have. Your your Zoladex or Lucrin injection, whether you're taking 6 months or 3 years. So I need that Gleason score. So whatever it is, biopsy is still needed. But compared to a metastatic disease, if your PSA is really like few hundred, few thousands, a patient do not have a biopsy, I'm quite okay with it. Because I just need a PET scan to see whether it's high volume or low volume. Then I can start my treatment based on that already. Okay. But another thing what we need to look forward is medical legal in Malaysia. Okay. If ever something happens, you do not have a biopsy, you'll get into a trouble. So PSA still, yes, you need, because I use it as monitoring. So a surgeon will normally see the patient, diagnose, do a PSA. If your PSA is high, then you still do a biopsy, get your Gleason scoring, everything, diagnose whether it's adenocarcinoma. And sometimes you might have some neuroendocrine differentiation also. And those normal treatment will not target your neuroendocrine where you need chemo actually. So I would say it is still, biopsy, traditional MRI, traditional PSA still has its big role. You still need it, but what I do is when they come to me, most of it is already ready. I just top it up a little bit with more of a personalized treatment to see what is specific to those particular patients.
Thank you. Thank you.
Next questions. Do we have questions for Dr. Shivani? In the back. So we welcome questions for the other panelists as well, yeah? So, there's a person. Oh, okay. This one first, if you don't mind.
I have a question from Clinic Kesihatan. I'm from primary care. So for Dr. Shivani, I have receiving a lot of patients who requested for genetic testing recently. They are healthy, without any obvious risk factor, moderate risk. And they are beginning to request for full genetic testing for all sorts of cancer, especially breast and ovarian cancer. So how do we in primary care, especially in government setting, to approach and to send this patient? Firstly, if cost are the most important factors. Thank you.
Thank you for your question. Okay, first thing I think would be to see a genetic counsellor. I'm from Cancer Research Malaysia, so we do have genetic counselling services. But if the patient does not have a family history or any other reason to do a genetic testing, they might not be asked to do it, and it's expensive, as you mentioned. So I think first get an assessment from a genetic counsellor, maybe get an indication of whether they need to do genetic testing, and then proceed from there. If you have, if you can contact our genetic counselling team at Cancer Research Malaysia, maybe if a patient is really keen, then maybe we can set an appointment with them, and then they can talk to them and see whether they are eligible for a genetic testing and so on. Yeah, yes.
I'll just add on to what Dr. Shivani mentioned. In the Ministry of Health, in the KL Hospital, there is a genetic clinic which is offered. But because of the limitations in terms of numbers, it's normally linked to family history, those who are high risk. If a patient without risk factors, it might be difficult in a government setting. But those with high risk factors, for example, in colorectal, those with FAP, that is possible. Thank you.
Hi, my name is Nix Suhaila from primary care. I have a question to Dato. Okay, in primary care, we've been doing IFOBT for many, many years, and we have a few patients that actually have IFOBT positive, but they refuse to go for colonoscopy. So my question is, what are the things that you say or do to actually increase the uptake for colonoscopy? And if they still refuse, what are the things that you do to this to this group of patients? Thank you.
Yeah, that is a challenge, because as I showed in my presentation, up to 40% of our patients, we do the screening, but we are not able to get them to come for the scope. So there are few things. One, our public health education that we are giving, I think we can improve on that. And if a patient is positive and they still do not want to come for the scope, the counseling is very important, I think. In terms of explaining to them the benefit of going for the scope, in terms of picking up a cancer early and the outcome in compared from early as compared to later. But I think in our country the problem is we do not have a screening program which is active. But if we do have, we should get involved the community leaders, as we were talking yesterday, the religious leaders, those who have a voice, those who have an influence over the public. I think that's the way that we can get them to understand and get them more involved. Yeah, I hope that answers your question. Yeah, please go ahead. Yeah, but that again is the problem with our test. The sensitivity is quite low actually, because even though it's positive, the ones that turn out to be cancer is actually quite low. That is the reality. But again, worldwide, that is the best that we have in terms of the tests that we have to pick up the early cancers. And we are waiting for the other newer tests, the DNA-based test, but that is the test that we have. So in terms of persuading, I understand your challenges because a lot of our patients, as much as we tell them, they are just not going to come in for the screening, for the colonoscopy or even for other cancers. It is a challenge. How do we do it? It goes back to counseling and building their trust, I think. And I do understand, I totally see the point that you are raising, that it's a challenge. And we will have certain numbers, and our statistics shows that 40% that who will just not agree for anything no matter what. So we have to face the reality, and we have to focus on those patients who would accept it and at least work on those who can. And those who are refusing, sometimes there's nothing that we can do further besides the counseling.
Do we have any other questions from the floor? I think we have time for a few additional questions.
Hi, morning. I'm Ashraf from Oncology UMMC. Just a question to Dr. Malvinder. What is the relevance for monitoring circulating tumor DNA in prostate cancer patients as compared to PSA surveillance? Thank you.
Sorry, you're asking surveillance with ctDNA and PSA?
Compared to PSA, what's the benefit of ctDNA over PSA surveillance?
Oh, okay. Okay, if we are looking at by guidelines, FDA have only approved ctDNA for colon cancer. Okay, other cancers they have not approved, but we know there are a few panels in Malaysia where we can do ctDNA for certain kinds of cancers, like lung cancer, gynae, GU cancers and all, a couple of cancers more. And FDA and WHO has also approved PSA as the only blood test where you can do for screening. Okay, so if you ask me, I've never done ctDNA for prostate cancer patients as monitoring. I just rely purely on PSA because PSA itself is already sufficient enough. Okay, and they show very, very characteristic compared to your disease burden also. So I rely more on PSA. ctDNA I do for other cancers. I don't do for prostate cancers.
Do you have any further questions? All right, so let me circle back to the question earlier. So, Dato, some of the biggest challenges when it comes to shifting the curve in early detection, if we want better outcomes for patients with colorectal CA, you talk about geographic barriers, in terms of access to treatment, access to screening, talk about lack of understanding, stigma. What do you think we need to focus on? What kind of strategies do we need if we want to get more people to come in for screening, to come in to get diagnosed at earlier stages? What are we doing? Looking at what we're doing right now, what can be improved upon? What needs to be overhauled?
Before we offer a national screening program, we have to see if you are ready or not. What we are doing now is being opportunistic, whereby we are giving the samples to those who come to the clinic, and we are subsequently going for the colonoscopy test. But if we do a national screening, are we ready? Because it's adding on to what is available in our hospitals. So this requires a large investment, because if you're going to have colonoscopy to be offered in many centers, there's going to be there's huge financial implications. So I think it's a matter of collaborating. So Ministry of Health, we have these programs available. NCCM, they've got these programs available. There are certain NGOs which are doing it. And often the problem that from my personal experience is we're all working in silos. Getting together, coming to the table and talking and working in a common strategy with a common good of helping the patient. I think that is where we are lacking. That's the way forward, I believe.
Thank you. So I think one way forward, they talk a lot in the health white paper, they talk a lot about public-private partnerships. Do you think this is likely the way to go? Because they're already doing this for initiatives in lung cancer, for example.
Yes.
And so for colorectal cancer, do you think this is going to be pretty much the same case?
Yes. There's already some certain initiatives in terms of private-public. In certain hospitals have started this. They are offering it at a subsidized cost because the numbers are going to be huge. I think that's got to be incorporated into what is already existing. And that's probably the way forward.
And it looks like the way to go will likely be integration into primary healthcare, into the primary care clinics where patients are being seen, as you say, they are currently being seen, screened opportunistically, where they are there serendipitously. If they are there for other conditions like diabetes, hypertension, that is where you offer them the opportunity to come forward and see whether they want to get screened. Do you think that the self-test kits are something that's going to help?
Going by the experience in Australia, that's where they have managed to shift the curve. Again, it takes a huge initiative in terms of getting it together and taking into consideration that we have so many cancers. Colorectal is only one of them. And the investment in terms of finances is going to be huge here. But we probably have to bite the bullet and do it, because cancer is such a huge burden in the country, causing in terms of treatment, in terms of management, it's a huge burden, personally, huge burden financially.
Thank you, Dato'. Dr. Shirani, might you like to comment a little bit on, Dr. Mawinda also talked about the use of AI in pathology, in risk screening, and how useful, how helpful do you think it's going to be? Do you think it's going to be a game changer? Is it something that's going to bring down the costs when it comes to screening, diagnosis, in terms of the speed at which we can diagnose the patient? What's your take on it?
I think the promise is there, but we first need to validate all of this. And I think what is important is having like a repository of images, because for AI, I think we're quite aware that we need tens of thousands of images just to kind of validate those methods, and we need to do it in our population independently of whatever that's been done in the West. Even for the mammograms, we can't really validate a lot of the methods out there because we don't have enough images, suitable images. So I think, first of all, I think, we can collaborate and get all a national repository of images, whether it's for breast imaging or other cancers, and then have it there so that when the methods are there, we have a resource and something that we can immediately reach out to and validate those methods, and then those can be used when they are ready. Yeah.
Thank you, Dr. Shivani. So essentially, you're saying that we need more research into the validation of the use of AI, And also we need the trials that you've done, the MESO study, for example, and all of this it needs to be scaled up.
That's right.
And-
Yes, power, power, statistical power, and we're always a bit underpowered in our study because we don't have enough numbers, and because of that, we can't really bring things forward. We need to validate, we need to confirm before we can actually say something or give a recommendation out there. So yeah, I think yeah.
That'll be the way forward.
Yes, yes.
Okay. So, any burning questions from the floor? Would like to raise your hand? Okay. So we could help getting a mic to the gentleman. Thank you.
Thank you. My name is Dr. Malik. I'm from the Cancer Society of Maldives, public health professional by work. We do a lot of screenings in the country and across the islands, and we do 5 screenings in particular: breast, colorectal, prostate, oral, and cervical. Especially for prostate, colorectal, and breast, is there any evidence that family members to be screened a bit earlier in age, because there's a lot of anxiety and people do come and request that they get screened because there's a family member who has a cancer of this particular group? That's the question. Thank you.
I'll answer for colorectal. In our national cancer register, our CPG, the clinical practice guidelines that we produced 5 years ago, the recommendation is that it's a family member with cancer, because the age in Malaysia is 50, whereby they start screening. That's a recommendation, even though it might not be implemented. But for those with a family member, it is 10 years younger than the age of the cancer patient. So if there's a family member who's 45 years old, then the first degree relatives should start their screening at 35. Should be earlier. Yeah.
That's the question at the front.
Okay. If you look at any cancer, obesity is a risk factor from any cancer from head to toe. Okay, but I wouldn't say obesity is the only factor. How a patient get cancer is a combination of multiple risk factors. But obesity is something which is very, very common in Malaysia, even in Asian countries also. And we do see colon, breast cancer. Those are 2 common cancers which is highly associated with obesity. But prostate cancer has its risks correlated to obesity also. But of course, it's multiple risk factor which accumulates and becomes cancer at the end of the day.
So specifically for colorectal, one of the risk factors is the diet, right, which is high in processed meat, low in fiber. So it is that's again obesity also is a risk factor as with other cancers.
So, any of the speakers, do you have anything else you might like to add? Any savanan for the people for our audience here? take-home messages that you might like to share?
Go for your screening. It saves your life, it saves your pocket also. You get diagnosed early, it's lesser treatment, cheaper treatment. When you get diagnosed late, it's more expensive and you have to go through many, many treatments.
Thank you. Thank you very much, Dr. Malwinder. I think that's a very important message to drive home for all of us. So I'd like to invite the speakers to remain on stage for the gift giving.
All right. What an engaging and insightful discussion we have had this morning. At this time, we will proceed with the brief token of appreciation ceremony with Professor Dr. Fitzgerald Henry, Dr. Shivani Mariapun, Dr. Malwinder Singh Sandhu, presented as a gesture of gratitude on behalf of the conference organizers. Thank you so much once again to all our esteemed speaker and moderator. Ladies and gentlemen, we will now take a short break for coffee and networking as well as to explore the booth exhibition located at the pre-function area and gallery. This coffee break will continue until 11 a.m. Hence, we'll see you back right in this hall at 11 a.m. When we return, we'll continue with our rapid fire presentations right here at JC1. Thank you.